shouldn't ask me any questions about the physics. That was another life ago, and I don't know how to do basic math anymore. I'm going to talk about just some neuro-ophthalmic perspectives of amblyopia. Much of this work we're familiar with, and I'm just sort of organizing it in a way that makes it easier for us to think about all the things that have been learned since the 1960s, especially. As we know, amblyopia was first defined by Hippocrates, described as when the doctor and the patient see nothing, which is what von Graefe said in the 19th century. But back when Hippocrates said it, it also included presbyopia. So we see the definition was much wider than what we explained today. But the best working definition one could come up with is as a potentially reversible, thus excluding that term organic amblyopia from the literature, and generally unilateral loss of vision that results from unequal visual experience during a sensitive period. And most of us can agree with that definition today. So the essential points are that it's potentially reversible, it's due to unequal visual experience, and has a sensitive period. And this sensitive period, of course, is defined as the time that if deprived of normal stimulation or unused, the neuronal functions development will be permanently disrupted. Now, this critical period begins only once visual experience is initiated. It doesn't happen in the womb and lasts between weeks and years, depending on the species and the visual faculty in question. Neurons with more complex response properties have critical periods that end later than those with earlier process properties. So those that are in the V1, what we measure with our visual fields, those are earlier process properties and have a shorter critical period than for those in the association visual cortex, which for recognition or so forth, which have much longer visual critical periods. So we're familiar with these pictures since the time of Hubel and Wiesel, where we see that the balance of left and right cells and the striate cortex, the primary visual cortex, can be tilted in favor of one or the other eye by manipulating early visual experience. And so visual deprivation, suturing of the eyelids, for example, results in reduction of cortical cells responding to the closed eye. This we're very familiar with, and it was done in experiments with kittens' eyes that were closed shut. We could define the critical periods by monocular deprivation after various delays following birth or at the time of birth. And this early monocular deprivation, we all know, is catastrophic to the visual system because it affects many critical periods. It affects the primary visual cortex, which is in association with all the other areas. So that's the worst to have, deprivation, amblyopia. And the Nobel Prize was awarded for this in 1981 for the work that was done in the 1960s in kittens. Van Noorden did this work in monkeys and macaques and showed it to be true there in primates in the 1970s. And it was one of Hubel's students, Jonathan Horton, at UCSF in San Francisco, who has continued this work from the 1980s to the present day using ever more sophisticated techniques for examining the brain cortex. And he's found some very interesting things. So remember, what Hubel and Wiesel did was deprivation amblyopia in kittens. And what we saw was the layer 4 of the primary visual cortex that was diminished. So this is monocular form deprivation amblyopia. But what of strabismic amblyopia? In that case, we see from Jonathan Horton's work, there have been no detectable changes in striate cortex that have been found. Using ever more sophisticated techniques, the changes we see in the striate cortex with deprivation, we do not see with strabismic amblyopia. And this is something that had been a bit overgeneralized before. We thought, well, amblyopia is amblyopia, we get changes in the striate cortex. Not true, that's only with deprivation amblyopia. The only changes in the brain that could be seen in about 10% of people, of animals with strabismic amblyopia, was shrinkage, slight shrinkage in areas of the lateral geniculate body. And that was in the minority of those who had strabismic amblyopia. Why would we have the lateral geniculate body affected? Well, we know that most of the fibers, most of the input to the lateral geniculate body doesn't come from the optic nerve, but is afferent input from the cortex. So it's actually possible that those 10% who had slight shrinkage of the lateral geniculate body, they may have had different input from their cortex back to the geniculate body. These might have been the ones who had very early onset strabismus with very strong fixation preferences. But the 90% of strabismic amblyopia, we cannot find any changes in the brain to this date. We also know there's refractive amblyopia. And what Jonathan Horton's work has found is that there can't be any difference found in the brain, no matter how refined the techniques used in monkeys, with human subjects, incidental autopsy findings. No anatomical changes have been found in the brain with refractive amblyopia at all. So we suspect there may be subtle changes in the metabolic activity. And all this has some clinical pertinence. We know the critical periods for amblyopia in macaques is about 4 times shorter than in humans. So you have monocular deprivation before 3 months of age in macaques, that is before about a year of age in humans, that is catastrophic. But if you don't have the deprivation early on, but only up to age 8, you can disrupt binocular vision still. What we were talking about earlier with primary versus association cortex. What's interesting is that the work of Hubel and Wiesel in deprivation amblyopia was done in the 60s, the Nobel Prize given in 1981. And it was several investigators, David Taylor and Craig Hoyt, who surmised that we could get better vision in infants by operating on their congenital cataracts very early on, before this deprivation amblyopia set in. And so the first study was published with a series of children in 1981 that showed excellent acuity. And it was so good because people thought kids who had monocular cataracts just were doomed to have bad vision, and many didn't even believe these results at first. It wasn't until the late 80s that this became routine, and now it's hard for us to believe it never was the case to operate early. And again, surgery for infantile cataracts is because it corresponds to the deprivation form amblyopia that we know has a short critical period. With strabismic amblyopia, we get suppression of activity in the cells of the striate cortex, but we don't get shrinkage of the cells. That's what we see now. And this suppression is similar to that of normal binocular rivalry, with, as Jampolsky pointed out as far back as 1955, a cigar-shaped scotoma and esotropia, but where there's no amblyopia unless there's a strong fixation preference. We get hemitemporal suppression with exotropia, but again, no amblyopia unless we have a strong fixation preference for one eye. And I just refer back to this paper by Arthur Jampolsky from 1955. He's soon celebrating his 103rd birthday, and I find this is still the best paper to refer to for strabismus suppression and leading to amblyopia. We now sort of subdivided amblyopia into 3 categories with anatomic correlates that are different. And the visual acuity that we see, the difference in visual acuity is also quite different. With deprivation amblyopia, we can get hand motion vision. It can be as bad as that, or light perception. But with strabismic amblyopia, we really don't have the peripheral retina that's suppressed. We have these central scotomas or hemitemporal suppression. So we do have vision that's on the order of 2200 or better, generally. We just recognize it's a suppression scotoma to avoid bifoveal diplopia, but the peripheral vision remains about the same. And with refractive amblyopia, the visual acuity is usually better than 2100. So we really have 3 different orders of magnitude of visual loss. One of the more interesting things though, about refractive amblyopia that we learned in recent years is that the anisometropic amblyopia we all know occurs when you have more than 1.5 diopter difference between the two eyes, does lead to a decrease in binocular fusion, which can allow for a microstrabismus that's really difficult to pick up in the clinic. And it's with this pediatric vision screening device that David Guyton developed, and David Hunter has also worked on, that can pick up deviations as small as 1 degree. But they've seen that the majority of those who have anisometropia also have a microstrabismus. So we may not just have an anisometropic amblyopia, but also a superimposed strabismic amblyopia. And the clinical characteristics of these two forms of amblyopia do differ. They're not exactly the same. The crowding phenomena that we often refer to in amblyopia, that only applies to strabismic amblyopia. The crowding phenomena, whereas we don't recognize letters that are surrounded by other letters, as well as letters that at the end of the chart are isolated areas, is due to the inability of the peripheral retina to identify targets that are surrounded by others. Foveal vision, with the fovea, we don't have a crowding phenomenon. So when we're looking with our foveas, it doesn't make a difference in our identification whether the letter is surrounded by others or not. But when it's the parafovea, that is even 1 degree off from the center of the fovea, we have difficulty distinguishing letters that are surrounded by others. So this crowding phenomenon, where we cannot identify letters surrounded by others, is not noted in the deprivation amblyopia or pure anisometropic amblyopia. So what's helpful for us to know this is it can help us determine whether we have a patient who has amblyopia in front of us, whether it's due to strabismus or anisometropia, or perhaps both. And why is that important? Because the critical periods for reversing, for treating these forms of amblyopia are different. With deprivation amblyopia, we can only hope for a benefit with occlusion up to age 4 or 5 years at most. With strabismic amblyopia, 8 or 10 years. But with the refractive amblyopia, again, we don't see any changes in the brain. There really is no age limit to when we can reverse that amblyopia. So if we see a patient who has anisometropic amblyopia, and perhaps they're 16 years of age, you do want to know whether there's a superimposed strabismic amblyopia from microstrabismus or not, to know whether to treat or not, or how hard to try. So that crowding phenomenon is a useful aspect to know. So when we go back to the time of Hippocrates, when amblyopia was used to also describe presbyopia, and now we're defining it a little bit differently, perhaps we shouldn't be using the same word amblyopia for deprivation, strabismus, and anisometropia, because we have a little bit difference in the treatment plan that we developed for them. We don't use organic amblyopia for the same reason. That's an old term nowadays because it's not reversible. Just to repeat what I said earlier, with deprivation amblyopia, the model by Hubel and Wiesel that got them the Nobel Prize, there was marked degradation of the striate cortex noted. Strabismic amblyopia, nothing, and only a few instances, mild shrinkage of the lateral geniculate body. And in refractive amblyopia, no structural differences found to date. So therapy will depend on the model of pathology. If it's deprivation amblyopia, the main issue is competition, what we saw in the striate cortex, and what Hubel and Wiesel found. So the clinical consequence is really patch the other eye as much as you can. And now when you have a congenital cataract and you can't operate on the child in the first week of life for logistical reasons or whatever, what should you do? Remember that amblyopia is a result of competition between the two eyes. You can halt the competition while awaiting for surgery. You can actually stop the unequal visual experience by patching both eyes. until the surgery is performed. It's like putting the child back in the womb. Amblyopia only begins with visual experience. If you can't equalize it by surgery, so not equalize it by closure. With anisometropia and strabismic amblyopia, there's also competition, but the main issue really seems to be disuse. We can get anisometropic amblyopia reversed even in old age. So the clinical consequence there is really try to straighten the eye to reduce the strabismus and give glasses early. These are our main approaches. Regarding congenital cataracts and deprivation amblyopia, we just said earlier, patch, patch, patch as much as you can. And yet remember that total occlusion will also cause strabismus and nystagmus, because if you have bilaterally poor vision before the age of 3 months, poor vision because you've patched the good eye all the time and the other eye still has a cataract, you're going to induce nystagmus, and you're blocking fusion, so you're going to induce strabismus. So part-time occlusion for moderate degrees of amblyopia, we know produces similar results to full-time occlusion. And in these infants where you have congenital cataracts, it's better to leave a little bit of amblyopia rather than to cause strabismus and nystagmus. So do patching half of waking hours, but not the full-time occlusion, despite this theory. That's what experience teaches. One of the other things noticed more recently is that most of the visual improvement in amblyopia occurs within the first 4 months of initiating therapy. So the question is, how long should we keep trying if we don't see improvement before we declare it a failure? It's still an open question. And patients with amblyopia associated with strabismus and anisotropia, we can first give them their full cycloplegic refraction, let them get better without the patching initially. The brain can only learn so much in a day. And then when we start seeing a peaking or plateauing rather of their improvement, then start patching to boot to try to minimize the inconvenience we give to families. We also know that visual acuity in the amblyopic eye and strabismus is frequently unstable. There's slippage. Need to do more follow-up even as adults, and probably give them their full cycloplegic correction. Maybe that will prevent slippage. Try to keep the eyes bifoveal. It's hard to define the sensitive periods for strabismic and anisometropic amblyopia. It's variable per individual. Anisometropic amblyopia, we know we can still correct until death. And in terms of the treatment, just remember that it's not a single disorder, amblyopia. John Sloper pointed it out, that it's really not a uniform condition. It depends on the abnormalities of visual experience that affect different aspects of vision throughout the critical periods that are different. And perhaps we should have different terminology and call deprivation amblyopia D-amblyopia, strabismic S-amblyopia, and refractive amblyopia R-amblyopia. Maybe we should start introducing this terminology. It would make it a lot easier for students and residents to know what we're talking about before they have to do a fellowship in pediatrics. So in terms of where we are today, we realize part-time patching is pretty effective, and full-time patching is rarely required. There's only so much a brain can learn in a day. Penalization, we know, is effective in many cases, and it's always good to give the full refractive correction, or at least eliminate the anisometropic difference. There's been talk recently of dopamine as a neurotransmitter, and how perhaps giving exogenous L-DOPA to boost brain dopamine levels might improve the treatment of amblyopia. The problem with this is that we know most of amblyopia is due to competition or disuse. And so how giving an oral medication to improve something that affects one eye and not the other doesn't have a very strong basis for it. The idea was that maybe it would increase the plasticity of the brain so we could treat it for longer. But that plasticity is still so variable for individuals, it's hard to define what it is to begin with. And the problem with giving L-DOPA, which through multi-center trials, the pediatric studies found it to be ineffective, But the problem that Craig Hoyt brought up in editorials too is that when we give exogenous L-DOPA, what are we doing to the very young child? These are large doses that are given. It might actually cause apoptosis of the dopamine-producing cells in the substantia nigra. And maybe we're decreasing their reserve of cells, and then when they're middle-aged rather than old, they might get Parkinson's disease. So that would be a very good long-term study for anybody who wants to take the patients that were in the PEDIC study and follow them 20 years from now, if someone's looking for a project, someone very young. So to learn from the past, many of the therapies previously suggested were based on reaction to previous failed therapies. And today we have a bit more of the science behind amblyopia, brain changes or lack of brain changes. And the implications for our treatment show that really it depends on our view of amblyopia, of where we should try with new therapies and perhaps avoid some like L-DOPA. And maybe a neuro-ophthalmic perspective could be helpful. Thanks very much.
Thank you, Dr. Parsa. It was an excellent presentation. I mean, really wonderful to have the neuro-ophthalmic